Well, hello. Today we're going to discuss out of chapter 4 in your positioning book. We're going to look at some of the anatomy and the positioning for the hand. Just to kind of recap, we've seen these before, but some of the bones in the right hand and wrist. We have 8 carpal bones, which we've talked about. There's a proximal row that has 4 and a distal row that has 4. So there's 8 in each hand, 16 total. We have 5 metacarpals labeled starting always with the thumb, which is number 1, and continuing on to the 5th digit or your pinky, which is always number 5. So we have 5 metacarpals. And then each of these is a phalanx. So in the thumb, you have a proximal phalanx and a distal phalanx. And then in digits 2, 3, 4, and 5, we have a proximal phalanx, a middle phalanx, and a distal phalanx. Each of these phalanx, which there are 14, there are 12 in digits 2, 3, 4, and 5, like 3, 6, 9, 12, 13, 14 in one hand. Each of these has a head, a body, and a base, just like the metacarpals have a head, a body, and a base. So each of those have 3 sections: head, body, and base in the metacarpal, and a head, body, and base in each of the phalanxes. These 3 phalanxes, proximal, middle, and distal, make up one phalange, or one finger, or one digit. In the thumb, you have 2 phalanxes, proximal and distal, and that makes up one digit, one finger, or one phalange. So all of them together are a phalange made up of a proximal, middle, and distal phalanx for digits 2 through 5, and a proximal and distal phalanx for digit 1. Some of the joints we have in the hand and wrist. We have joints between each of the carpal bones, but we don't typically refer to those a lot. But between the carpals and the metacarpals, we have what are called carpometacarpal joints, CMC joints, carpometacarpal joints. Then at the distal end of each metacarpal, where they join with the proximal phalanx, we have metacarpal phalangeal joints, or your MCPs. We typically refer to these as your knuckles, so your metacarpal phalangeal joints. In the thumb, since we only have a proximal and distal phalanx, you have one joint between them, and that is called the interphalangeal joint, or the IP joint. In digits 2, 3, 4, and 5, we have a proximal, a middle, and a distal phalanx. So you have what are called proximal interphalangeal joints, or PIP joints, and you have DIP joints, or distal interphalangeal joints. So we have DIPs, PIPs, IPs, MCPs, and CMCs in the hand. If we look on page 129, again, this is a review of the anatomy where you can identify the carpal bones, the metacarpals, the joints associated with each of the phalanxes, the head, the body, and the base, the tuft of the finger. We talked about a tuft fracture would occur at the distal end of the distal phalanx. So make sure you look at that, because ideally you should be able to identify every aspect of this right hand radiograph. If we go look at the positioning for a hand, a routine hand includes a PA, a 45-degree lateral oblique, and a fan lateral, which is also considered a lateromedial. The technique for the hand is 65 kVp at 1.2 mass. So notice from fingers, where we were at 60 kVp at 0.8, now the hand is a little bit thicker as a whole, so we go up to 65 kVp at 1.2 mass. Some of the specialty views include an extension lateral, a flexion lateral, the Norgard method, or the ball catcher's method, and those are both done to demonstrate rheumatoid arthritis. But the routine hand has 3 views, a PA, a 45-degree lateral oblique, and a fan lateral. If we start with the PA hand, this is on page 150. And again, they have a small IR. Typically, the IR size we are going to have in the field is either a 14 by 17 or a 16 by 16. And what you want to always do is attempt to place the anatomy at the central ray in the center of the image receptor. This is because with our digital systems, they tend to read from the center out. So centering the anatomy that you want in the center of the picture to the center of the IR is essential, as is collimation. You absolutely have to collimate on these to get the most diagnostic image that you possibly can. Okay, marker is placed on the lateral aspect. Now this is correct. Remember I told you in the last lecture that the images will hang fingers up, and we'll look at that in just a second. So even though this looks upside down to us, when it's hung, it will read correctly to the radiologist. So on the lateral aspect of the part, so when you're looking at the right, it means it would be to the right of the part. So if you were over here looking at that, this would be medial and this would be lateral. Now personally, I would place the marker, if it was me, I would place the marker here. Well, that wouldn't be in the light field, but let me try that again. I would place the marker right there. Then I could collimate a little bit more this way. I wouldn't run the risk of interfering with any of the anatomy there because it would be above the 5th digit. So that's where I would place the marker. And then just like they have it, the marker would be placed. Oops. Marker would be placed so that it read correctly when it hangs. Okay, so the right up there. On a PA hand, again, the technique is 65 kVp at 1.2 mass. And the central ray is at the 3rd metacarpal phalangeal joint, or the 3rd MCP, so where the metacarpal meets the proximal phalanx. We also, lay terms, you would call that the 3rd knuckle. Okay, not that I want us to use lay terms, I'm just trying to show you as far as a frame of reference. So at the 3rd metacarpal phalangeal joint is where the central ray is. So the patient would pronate their hand or place it flat down. Sorry, this is what I was trying to show you, is where the 3rd metacarpal phalangeal joint is. Patient would place their hand flat down on the image receptor. Palmar surface would be in contact with the image receptor. And notice how you spread their fingers out slightly so that no soft tissue is touching. Okay, that's important, especially if there's swelling. You want to make sure the radiologist can visualize in between the soft tissue. So notice there's no jewelry, no bracelets, because we do have to include 1 inch of the distal radius and ulna. So 1 inch of the wrist has to be included. No rings on the patient, no bracelets, no watch, nothing to interfere with the image whatsoever. So the central ray is at 3rd MCP, and notice the long axis of the part is along the long axis of the IR. That's important as well. Once we take this image, we look at it to evaluate. We need to see the entire hand and the carpals. So the hand, all the carpal bones, and you do need 1 inch of the distal radius and ulna, which is acceptable right here. The center of the field, meaning the center of the IR, is at the 3rd metacarpal phalangeal joint. So if you were to make an imaginary line down the center and the center, ideally the center would be right here. So the center of the field is at the third MCP, which means you've placed it correctly as far as positioning the patient on the image receptor. There's no rotation of the phalanges or the metacarpals, meaning it's placed flat down, palmar surface in contact with the IR. And again, we use 65 kVp at 1.2 mass for this. Notice the joint spaces are nice and open on there. Whatever your patient's injury was, you want to look and make sure that you have that well imaged on there so that you can see anything that might be going on for the radiologist. And again, it hangs fingers up. The marker is the correct marker, but again, if I was doing this, I would likely place the marker here, and then I would also make sure that it read correctly. I would have my marker like that versus down here. Okay, so it goes lateral to the part. So this is a right hand, so it goes to the right of the part. If it was a left hand, it would go to the left of the part. So when I say lateral to, if it's right, it goes to the right. If it's a left, it goes to the left. Okay, so that is our PA hand. Our next image is on page 151. And we actually do a 45-degree lateral oblique. Remember I said when we do obliques, we need a degree of rotation and a direction. So you need a degree of rotation, which is 45, and direction is lateral. So it's a 45-degree lateral oblique because the hand is rolling up or away from midline. Okay, so this right hand is rolling up, meaning that the thumb is coming up. If it was medial, then the thumb would have to be going down towards the IR. So it's a 45-degree lateral oblique. This again is on page 151. So you want to center the hand, ideally the third MCP in the center of the IR. Now they do show it with a sponge. I will tell you that we used to use these quite often. Now they're typically not used anymore because remember, this is a very porous material and there's no way to clean that. So a lot of facilities got rid of and did not replace. This is called an oblique sponge. The reason for that is you could order a new oblique sponge. The problem is they're very expensive, and most of the time you might need it in the very beginning when you're learning to position, and then shortly after you don't need it anymore. You start to get a feel for what a 45-degree oblique is. You tend to look at the top of the hand and the bottom of the IR and look for that 45-degree angle between the two. The biggest thing with the oblique is that you have to make sure the digits are parallel to the IR. It opens the joints. This one here is figure 4.70 on 151, where the digits are parallel to the IR. This one, I tend to call this one the lazy oblique because they're not parallel. Notice the fingers are actually resting on the IR, so there's no way that the joint spaces are going to be open for that because the fingers are not parallel. They're actually touching here and not touching here. So this is not what we want, okay? This one is no bueno. We don't want that. We want this one, okay? So when we look at that, you want the digits parallel to the IR. If the digits were not parallel, the only excuse to do that is if you were only interested in the metacarpals. Nothing at all with the fingers, only the metacarpals, then you could do this one. As far as our evaluation criteria, we have to demonstrate the entire hand and all carpal bones, plus we need 1 inch of the distal radius and ulna. The center of the field should be at the third metacarpal phalangeal joint. The joint spaces should appear open, meaning that the digits were parallel to the IR. So if you look at these joint spaces here, the the distal interphalangeal joints, the proximal interphalangeal joints, the metacarpal phalangeal joints should all be open. This is the interphalangeal joint. All of these should be open joint spaces. There should be adequate separation of the phalanges and the metacarpals, meaning these you should see space in between. Typically on the oblique, the third, fourth, and fifth start to overlap kind of significantly, but there is definite separation of the fingers, no overlapping of soft tissue. All right, and central ray again was at third MCP, and technique is 65 kVp at 1.2 mass. The third view that we do is actually called a fan lateral, and this is on page 152. And the reason it's called a fan lateral is because the fingers are fanned out or separated like that. All right, the central ray on this now goes to the second metacarpal phalangeal joint, which is still in line with the third. It's just with the hand lateral like this. You're not gonna move back and center here. You're actually gonna center on the one that is on top. And that second, realize that if she was completely lateral, which she is slightly off, then the second would be right over the third. So same centering as we've been doing. It's just that now you can't visualize the third, so you're actually doing the second. Okay. Typically what I have the patient do for this is I tell them to put their hand on their side and make an OK sign. Right? These would be touching with an OK sign, but then you tell them to separate their finger and thumb. You don't want the fingers touching when you do that. It obscures the anatomy and it closes the joint spaces. So notice how there's an opening here. You don't want these touching. As far as the evaluation criteria in this, you have to, again, see the entire hand and all the carpal bones. You need 1 inch of distal radius and ulna. The center of the field is at the second metacarpal phalangeal joint. The fingers are separated. Now this is a little close, but there is, you can see air space in between here. You can tell that they're not touching, so that's acceptable. But if they were touching, that would not be acceptable because you would close these joint spaces here. Okay, so fan lateral, marker placement is acceptable for this one. Notice again, it hangs fingers up. Marker is visible and visible to the radiologist who would be evaluating this image. So those are the routine that we do. We do a PA, a 45-degree lateral oblique, and a fan lateral. Some alternate lateral hands that they do, and these are on page 153. You can do what's called an extension lateral or a straight lateral and a flexion lateral, where you can tell the hand is flexed and the hand is extended. Okay, those are on page 153. So it is possible that they might ask for an extension lateral, especially if the injury is in the metacarpal. Sometimes they'll want an extension lateral because then you'll be able to visualize anterior posterior aspect. So if one of the metacarpals was fractured, sometimes you can actually see it sticking out. You can make out the fracture sometimes a lot better. Excuse me. Make it out a lot better in a straight lateral versus the fan lateral. You can still see, if we go back, you can still see in a fan lateral. Now this isn't very well exposed. It could have been that the injury was more to the fingers, somewhere up in here, but if this was your actual image, you would want to make sure that this was penetrated more so than what that demonstrates. Okay, this penetration here is more acceptable. The radiologist can see through. Even though the metacarpals are superimposed on top of each other, that is a much better image than the one we looked at previously. So it is possible they could ask for an extension lateral or a flexion lateral. And then some of our specialty views that we have on page 154, we have what's called the Norgard method, or the ball catcher's view. Okay, now I don't have an image showing the hands, but if you look on page 154 at figure 4.83, that is what the hands would look like for the Norgard method, the bigger picture where her hands and her fingers are extended and straight. That is the Norgard. The ball catcher is where they simulate, like if you were going to catch a ball, if you told an adult, put your hands out like you're going to catch a ball, you would put them out and your fingers would kind of be bent. So that little inset picture, that is called the ball catcher's position. Now this is done, both of these views or either of these views are done to demonstrate rheumatoid arthritis in the 2nd through 5th proximal interphalangeal joints and metacarpal phalangeal joints. Okay, so the patient would supinate both hands and place them in the center of the arm. They would rotate their hands internally or bring them towards each other 45 degrees, extend the fingers, and they would separate and elevate their fingers. Or you could modify the position and simulate it to catching a ball so that you could bend their fingers. And the central ray would go midway between the 5th metacarpal phalangeal joints, so between both hands. If we look at this, it's a little easier. So central ray would be midway, like right here, between both. All right, now these joint spaces are open, so this is actually the Norgard method that they did. If they did the ball catchers, then these joint spaces would be closed because the fingers would be curled. All right, so you see bilateral hands in a 45-degree oblique. You see the mid shafts of the 2nd to the 5th metacarpals, and the base of the phalanges are not overlapped. The metacarpal phalangeal joints should be open, and the exposure factor would be the same, 65 kVp at 1.2 mass. And again, this is done to demonstrate rheumatoid arthritis for the patient. And if they bend their fingers like in the ball catcher, then you're ideally looking at the metacarpal phalangeal joints. But if the fingers are extended, like the Norgard method, then you're looking not only at the MCP joints, but you're looking at the proximal interphalangeal joints as well. So that concludes the lecture on the hand and the imaging and the specialty views, and we will discuss this during our live session.